Yep. Thank you. So I'm going to be talking about cannabis and its role in pain and palliative care, and I do want to say that cannabis changed my life. In 1992, when I was an AIDS oncologist working with people living with HIV, before we had really effective therapies, I received a letter at San Francisco General challenging me to study cannabis in patients with the AIDS wasting syndrome. Again, before we had effective treatments, many of our patients died of this awful loss of weight, diarrhea, fever, no appetite. And there was a suggestion that cannabis may be useful in that situation. So I said, okay, I can do that. I went to college in the 60s, and I fought the government for a while and ultimately won and received cannabis and money to do research. And that gave me a strong appreciation of the power of plants as medicine, which ultimately took me to my fellowship in integrative medicine, the 2-year online distance learning fellowship offered by the University of Arizona, Andrew Weil's program. And when I finished that in 2004, I said, I'm done with HIV/AIDS. I've been doing that for 25 years. It's very different from when I started. And what I want to devote my life to now is integrative oncology, integrating complementary and conventional care. I am chief of oncology at San Francisco General, and I have a practice where I do integrative oncology consultation at the UCSF Osher Center for Integrative Medicine. And very rarely does a day go by at the Osher Center that I don't recommend cannabis to patients that I see living with and beyond cancer. Cannabis is one of the oldest known psychoactive plants, and evidence from archaeologic digs suggests that it was first used probably in China 2,700 years ago. A tomb that has the remains of what appears to be a Caucasian shaman had on either side of his head a basket or a clay pot that had the flowers of the female cannabis sativa plant with it, suggesting that this person was either a shaman or some sort of religious person who understood the power of the resin exuded from the flowers of the female plant. It's then felt that cannabis went over the Silk Road to the Indian subcontinent, where it was recognized first by W.B. O'Shaughnessy, who worked for the British East Indies Company, and he brought it to the United Kingdom in the 1840s. Apparently, it ultimately became Queen Victoria's favorite treatment for her menstrual cramps. At the end of the 1800s, cannabis had many potential uses, analgesic, sedative, anti-inflammatory, antispasmodic, etc. The interest waned in the use of cannabis in this country in the early 1900s with the availability of specific agents, targeted therapies, if you will, that spoke to all of those indications that cannabis previously held. And the real death knell to the use of cannabis as medicine in the United States was the introduction of the Marijuana Tax Act in 1937 by Harry Anslinger. Harry Anslinger was a prohibitionist who was also the first director of the Federal Narcotics Bureau. He was a bit of a racist, and he felt that widespread use of cannabis by African-American jazz musicians and Mexican south of the border laborers would lead to increased crime and mental illness in the United States. So he sort of did an end run around physicians and introduced the Marijuana Tax Act, using the Mexican name to associate it with nefarious south of the border goings-on. And this act, which was passed by Congress and opposed by the American Medical Association, imposed a $1 an ounce use tax on medical use of cannabis and $100 an ounce for recreational users. And remember, this is $1937, so these were significant levies that were applied. Interestingly, then, cannabis was removed from the U.S. pharmacopoeia first in 1942. So it's been a medicine for 3,000 years. It hasn't been a medicine in this country for 70 years. And 1942 is another significant date because that's when Fiorello LaGuardia, the mayor of New York City, commissioned the LaGuardia Commission to investigate whether cannabis use was in fact going to lead to increased crime and mental illness, and they concluded that it would not, that it was a useful medicine and it should be allowed to be prescribed. Interestingly, every 10 years since 1942, some august government body in the United States has reinvestigated Cannabis as Medicine, the last being Marijuana as Medicine by the Institute of Medicine, a report that came out in 1999. And every time these reports come out, they have the same conclusion, but these are widely ignored. Cannabis was placed by the Controlled Substances Act in 1970 in Schedule 1. Schedule 2 substances we can write prescriptions for with a special prescription pad. They have an accepted medical use. Both Schedule 1 and Schedule 2 are agents with high potential for abuse, but the difference between Schedule 1 and Schedule 2 is that Schedule 1 substances have no accepted medical use. And that's where cannabis is, despite the fact that the Institute of Medicine says that it's useful in pain, anorexia, and nausea and vomiting. These are the other substances which are in Schedule 1 along with cannabis. When I first became interested in looking at cannabis as medicine, my colleagues, oncologists often, said, how can you be interested in a plant? The plant contains over 400 chemical compounds, and our Western pharmaceutically dominated paradigm is that you isolate the single most active moiety and put that in a capsule, and that's a drug. Yeah, it's true that cannabis contains over 400 compounds. The highest concentration of the bioactive compounds are found in the resin that's exuded from the flowers of the female plant. The main psychoactive component is believed to be delta-9 tetrahydrocannabinol, but there are at least 70 other related compounds in the plant that may be beneficial. For example, a study in Israeli children with cancer undergoing chemotherapy demonstrated that delta-8 THC is similar in potency as an antiemetic to delta-9 THC. Of course, this is present in the plant, but not in the medicines that we have available in this country that are synthetic delta-9 THC. For any of you that know patients using cannabis, there are other cannabinoids that have medicinal benefit, and one that's very popular in the community right now is CBD, or cannabidiol. CBD probably modulates the pharmacokinetics of THC and provides some of the yin to the yang, if you will, of THC. It possesses itself properties that are sedating, reduces anxiety, and other unpleasant psychological side effects of pure delta-9 THC. So CBD in and of itself is not psychoactive, and it's a very potent analgesic and anti-inflammatory. So many patients that I see are seeking cannabis that's high in CBD and low in THC, just to speak to the needs for which they're using this medicine. Again, there are 400 different compounds in the plants, and it's not just these cannabinoids that have potential pharmacologic activity. The terpenoids, which give the cannabis its unique smell, also seem to be agents that we're familiar with in other botanicals that themselves have biological activity. Raphael Mechoulam, an Israeli chemist who's really the father of cannabinoid chemistry, believes that anybody undergoing an acute brain injury, such as a traumatic concussion or a stroke, should be exposed to cannabinoids because they decrease the extent of brain injury by enhancing cortical activity and increasing cortical blood flow. So certainly something we haven't yet seen in emergency rooms or neuro ICUs, but something to think about. Now, although there has not been a lot of research on cannabis as a medicine over the last half century, there has been a lot of progress in understanding how cannabis works. We've identified two receptors in the body, the so-called CB1 and CB2 receptors. And these receptors look like standard physiologically active 7 transmembrane domain receptors. So they are in the cell membrane, and when they complex with cannabinoids, be they from the plant or from cannabinoid medicines, they yield to changes of many of the pathways inside the cell cytoplasm that yield to changes in control of cell function. This is a demonstration of where CB1 receptors are in the rat brain, with the highest concentration of receptors found in the orange color, so the cerebellum and the periaqueductal regions. Actually, interesting, CB1 receptors are the second most densely populated receptors in the human brain. We didn't learn anything about that when I went to medical school. So the CB2 receptor is the other cannabinoid receptor that originally was felt not to be present in the brain, but was detected in cells of the immune system, the macrophages and the marginal zone of the spleen. And the highest concentration in the peripheral blood is present in the B lymphocytes and the natural killer cells, which we've heard quite a bit about during the course of this meeting. And this suggests that cannabis may have something to do with the immune system. So why do we have these receptors, CB1 and CB2 receptors? And these receptors are found in all animal species down to sponges. You know, we've never seen a monkey or a dog smoke cannabis, so why do we need to have receptors? Well, again, Raphael Mechoulam and his group identified the first endocannabinoid. Just as we have endorphins, endogenous opiates, we also have endogenous cannabinoids, the body's own cannabinoids that are made on demand. He named the first cannabinoid that he identified anandamide after the Sanskrit word for bliss, not bris. The second most commonly recognized endocannabinoid is 2-AG. So why do we have cannabinoid receptors and endocannabinoids? Michael Pollan, in his wonderful book, The Botany of Desire, suggests that the reason we in all animal species have endocannabinoids is to help us to forget. So while I'm standing here talking, I'm not remembering where I parked my car or when the last time I gave this talk, so I can concentrate and focus. And then if you displace your endocannabinoids with plant cannabinoids, you forget to forget, and everything, wow, is very novel. So now, Michael Pollan, in his next book, The Omnivore's Dilemma, is trying to gather all of his food by himself, and he's crouched with a gun in the woods waiting to shoot a deer. And he said, this is painful. I don't like being in this position, but if I were dependent on doing this to get my prey, then I would have to tolerate this pain. So he postulates that the reason we in all animals have endocannabinoids is to help us forget the pain that we generate when we're hunting for our food. So it's a self-preservation mechanism. The endocannabinoids are synthesized on demand from the membrane of the cell, and then they're also metabolized by a fatty acid amide hydrolase. And this elegant drawing suggests that when endocannabinoids complex with the CB1 receptor, they cause changes in the cells that lead to change in appetite, immune function, muscle control, pain, intraocular pressure, thinking, emesis, etc. When cannabinoids interact with the so-called CB2 receptor, they impact on immune function, very important for cancer, cell proliferation, and inflammation. Actually, all of these very important for cancer. And it's felt that the cannabinoids also interact with the so-called vanilloid receptor, again, to invoke changes in pain and inflammation. And there are probably other as yet unidentified cannabinoid receptors. So notice the presence of pain in all of these different receptor activities. So let's talk for a moment about the topic here, which is cannabis use in cancer patients for pain and palliative care. The symptoms that we see in our patients with cancer are well known to all of us, either living with or beyond cancer or taking care of our patients. Weight loss, cachexia, early satiety, anorexia, pain, anxiety, depression, and acute nausea and vomiting. And as somebody who's been working with cannabis as a medicine really since my fellowship, I'll tell you that cannabis is one medicine that actually is useful in pretty much all of these situations. The first sort of look in our country of cannabis in chemotherapy-related nausea and vomiting came in the 70s. If you remember the 70s, Jimmy Carter, very loose on cannabis. A lot of young people used cannabis. Some of those young people, unfortunately, may have developed Hodgkin's disease or testicular cancer, which are two cancers that we had chemotherapeutic interventions for back in the 70s, and both of them created a lot of nausea. Back in the 70s, in oncology, we didn't have many effective antiemetics like we do today. So many young patients with cancer told their oncologist, gee, you can keep that prescription medicine, it doesn't do anything, cannabis works. And that's where really the first indication that cannabis may be useful in chemotherapy-induced nausea and vomiting came from. And in randomized trials, oral THC was found to be better than placebo and equivalent or superior to what we had available as a prescription med. And smoked THC appeared superior to oral. Now, currently, when you line up our armamentarium of interventions in nausea and vomiting, cannabis might not be the most potent, but frequently I see people who say that the only thing that worked for their chemotherapy was cannabis. And I believe it was Melissa Etheridge who came out as a cannabis user for treatment of her nausea and vomiting for her adjuvant chemotherapy for her breast cancer, which really brought to center stage the issue that if it helps for some people, why should it not be available? Cannabis was approved, or delta-9 THC, dronabinol, the single ingredient that's psychoactive, was approved for treatment of chemotherapy-induced nausea and vomiting in 1986. In 1992, AIDS patients with the wasting syndrome that I mentioned to you became aware that there was a so-called compassionate use program from the government where they would send a handful of patients with orphan diseases 300 cannabis cigarettes monthly, even though there's no medical use. They were sending it to patients in this program. And there was a concern that AIDS patients with wasting, which was also considered an orphan diagnosis, were going to flood the government with requests for 300 cigarettes a month. So they closed the compassionate use program. And to say that they were doing something, they increased the availability of dronabinol by expanding the license indication. Now, if you read carefully the advertisement, it doesn't say it's for the treatment of weight loss in AIDS patients because placebo-controlled trials did not demonstrate any benefit in increasing weight. What it did was increase appetite. But so that the government can say, see, you don't need cannabis, you have dronabinol, they expanded the license in 1992. So we started to prescribe dronabinol to patients with AIDS wasting, and they said, you know what? I don't like it. It takes a long time for the effect to come on, and it lasts a long time, and you really get zonked. And what the patients were describing was the pharmacokinetics of THC taken orally. When taken by mouth, there is a very low and variable bioavailability. Only 6 to 20% of the oral dose gets absorbed into the bloodstream. And the peak plasma concentration is achieved in 2.5 hours. So if you're trying to take this dronabinol to increase your appetite before breakfast, you either have a late breakfast or you get up very early. And the terminal half-life when taken by mouth is 20 to 30 hours. The key, however, is that when taken by mouth, the delta-9 THC goes through the liver and gets metabolized into another psychoactive metabolite, an 11-hydroxy-THC. And that much less of this is formed when cannabis is inhaled. So very frequently, I see elderly cancer patients who want to try cannabis and feel that eating is normal and good and smoking is bad. And so when they go to the dispensary, they ask for a baked product. And they get a cookie and they're told, just eat a quarter. And they do, and nothing happens. So they eat another quarter, and nothing happens, so they eat the whole cookie. And then they call me 3 days later and say, what did I do? I'm not going to do that again. So that's why smoked is probably the wrong word here now. I should change that to inhaled, because there are other ways to inhale cannabis rather than combustion. But when inhaled, it's rapidly absorbed in the bloodstream with a considerable amount lost by the process of combustion if you're smoking it. less so if you're vaporizing it. But the important thing is that as opposed to having a peak concentration that occurs late and is very low and lasts for a long time, it's much more like an intravenous bolus. So you get a peak concentration in 2.5 minutes, which rapidly declines over the next 30 minutes. And again, much less of the 11-hydroxy psychoactive metabolite is formed. So I really like people to inhale cannabis most of the time. So what do we know about appetite? Anandamide, that endocannabinoid that I mentioned, in low concentrations in mice leads to a potent enhancement of their appetite. The CB1 receptors are felt to be implicated in control of food intake working by the limbic system, so it's a motivational reward aspects of eating. Interestingly, if you take mice and genetically engineer them so they don't have a CB1 receptor, they eat less than their wild-type litter mates. They've also found the other endocannabinoid, 2-AG, is present in high amounts in mother's milk. So they did an experiment where they gave mice a CB1 antagonist, and those mice, newborn mice, at 24 hours, they stopped suckling and died. So this lit up the minds of many pharmaceutical companies, thinking that if you block the CB1 receptor and reduce the motivational reward aspects of eating, you might have a drug that can help people lose weight. And rimonabant, otherwise known as Acomplia, is a drug that was a CB1 receptor antagonist that was approved all through Europe because clinical trials demonstrated that in overweight people, if they took this CB1 receptor antagonist, they lost weight. Now, one of my colleagues who co-authored the chapter in our textbook, Integrative Oncology, the chapter I wrote was on cannabinoids and cancer. Manuel Guzman is a PhD in Madrid who studies the anti-cancer activity of cannabinoids, which I'll talk about in a moment. And I was in a meeting in Europe once. I said, Manuel, how is that drug doing? He said, Donald, would you take a drug that blocked your CB1 receptor? Because from animal studies, it's known that yes, if you block the CB1 receptor, hence also turn off the endocannabinoid system, you do get suppressed feeding and weight loss, but you also increase anxiety, and you create anhedonia, the inability to experience pleasure. And so this, in the animals, led to melancholic depression. The drug is no longer available in Europe because guess what? Blocking your CB1 receptor led to depression and suicide. And people, yes, lost weight, but at quite an expense. So let me go back to pain, because I think this is really very exciting and where I've done most of my research. Elevated levels of the CB1 receptor, like that of the opioid receptor, are found in areas of the brain that modulate processing of noxious stimuli. CB1 and CB2 agonists also have peripheral analgesic action, so it's not just the brain. And cannabinoids and other components of the plant may have anti-inflammatory effects. The analgesic effects of cannabinoids are not blocked by opioid antagonists, suggesting that they work by different pathways. Given intravenously, THC is potently analgesic, and again, it appears linked to the opioid system, but through different pathways. 20 milligrams of oral THC was felt to be comparable to 120 milligrams of codeine, but there was marked psychological effects. Now, important for cancer patients is the problem of neuropathic pain. At this point in time, I have many patients who are cured of their cancer but are disabled by painful numbness, tingling in their hands and feet. And cannabinoids, unlike opioids, are effective in a rat model of neuropathic pain. The model being the tail flick, where the rat's tail is put on a hot plate, and the longer they can keep it there in response to a given drug, the more it suggests that this might be something useful in human neuropathic pain. So we conducted a clinical trial in patients with HIV-related peripheral neuropathy back a while ago. Let me just make a comment that the only legal source of cannabis for research in the country is NIDA, the National Institute on Drug Abuse. And NIDA has a congressional mandate to only study substances of abuse as substances of abuse. So they cannot fund clinical trials that that are looking at the potential medical effectiveness of cannabis. So we were fortunate in the state of California at the end of the last century to have a budget surplus. And John Vasconcellos, a state senator, appropriated $3 million a year for 3 years to establish a center for medicinal cannabis research that was actually based here at UCSD. And with monies from that, we were funded to do a number of clinical trials actually looking at the potential clinical benefit of cannabis using NIDA cannabis, because again, they're the only legal source. So opiates are ineffective for HIV neuropathy, and there was some anecdotal reports that cannabis was useful. So we did a clinical trial that was published in the journal Neurology, and it was actually a randomized placebo-controlled trial. Talk about issues with placebo that we've heard about this morning. But we took 50 patients with peripheral neuropathy and randomized 25 to inhale true cannabis and 25 to inhale cannabis placebo over a week's period. Now, we established that sample size by first doing an open-label pilot study to determine the effect size that we would need. And in addition to doing the response of the peripheral neuropathy to the cannabis or placebo, we also induced pain experimentally. We heated the forearm of the patients to 104 degrees for 15 minutes and applied after that capsaicin cream. Capsaicin is the active ingredient in chili peppers. And this creates an area of allodynia and hyposthesia, hypersensitivity and weird feeling that you can map with the person looking in the other direction before and after using your drug, the analgesic. And this is what my colleagues from the Pain Clinical Research Center use for evaluating analgesics. So this is the result of our placebo-controlled trial. We asked patients to keep a diary of their neuropathic pain for the week before they came into our clinical research center. All of our studies are done with patients sort of incarcerated, if you will, in our clinical research center because they're in a Schedule I trial. They're not allowed to leave the center. Spending the first 2 days without any intervention, the pain decreased a little bit. After smoking cannabis, you can see we set as a threshold a 30% reduction in pain. 54% of the group smoking cannabis had a 30% reduction in pain compared to only 24% of the placebo group. And at the end of the inpatient study, we asked patients to keep a diary again without using cannabis at home, and you can see their pain went back to baseline levels. Interestingly, after smoking the first cannabis cigarette in the clinical trial, the placebo group rated their pain, their neuropathic pain decreased 19%, where the group smoking true cannabis said their pain went down 74%. These are the results of what happened to the experimental pain model. The top line is the placebo group, and the bottom line is the group smoking true cannabis. So you can see a comparable effect in the experimental pain model. So we concluded that smoked cannabis is an effective treatment in patients with painful HIV-related peripheral neuropathy, and it was also effective in the experimental pain model. The magnitude of the effect, that is, the number needed to treat for one person to have a benefit, was 3.6. Gabapentin, which is an anticonvulsant that we use most commonly in treating peripheral neuropathy, in another study, the number needed to treat was 3.6. The Center for Medicinal Cannabis Research funded 2 or 3 other studies of cannabis in peripheral neuropathy, and the number needed to treat in all of them is 3.5, 3.6, or 3.7, showing very much consistency of these results. Unfortunately, we have not yet done a study in patients with cancer-related or chemotherapy-related peripheral neuropathy. I've tried to do 4 studies in cancer patients with cannabis, and I've failed on all of them. One of my cultural anthropologists says, we need to study that. So maybe someday we will. The last study that we did, I think, is also very important for our cancer patient population. Again, cannabinoids and opioids share several pharmacologic properties, and initially they were thought to work on the same pathways, but now we know that they're different. And in mice and rats again, THC greatly enhances the analgesic effect of opiates in a synergistic fashion. So 1 + 1 = 5, not 2. So there's a possibility that we can treat people with chronic opiates at lower doses for longer periods of time if they are given with cannabinoids. So this study actually was done after the Center for Medicinal Cannabis Research ran out of money, and I was able to get this supported by NIDA because it was a safety study. The question is it safe for patients on chronic opiates to add cannabis to their regimen? So we took patients who are on sustained-release morphine or sustained-release oxycodone, and we admitted them again to our General Clinical Research Center. On the first day, we took 12 hours of blood sampling to map out the area under the curve of their opiate. And then after the first day, patients vaporized cannabis 3 times a day. And on the last day, day 5, we again drew a 12-hour sample to see what the effect of adding cannabis was to the level of opiates in their bloodstream. And when you do these so-called pharmacokinetic interaction studies, you don't need a lot of patients. So we had 10 people who came in on morphine and 11 on oxycodone, both of those sustained release. The opiate dose was 60 twice a day for the morphine group and 50 for the oxycodone. And the morphine group came in with a slightly lower pain score, 35 out of 100, compared to 44 for the group that was on oxycodone. So this is the result of the study. The top line is day 1, and the bottom line is after exposure to cannabis. You can see, if anything, although it's not statistically significant, the cannabis seemed to lower the blood levels of the morphine. There was no real effect on the blood levels of the oxycodone at all. Looking then at pain, because since we were doing this, we thought, well, you would expect that if there's no change in the concentration, or if the concentration of the morphine decreased, that pain relief would also decrease. But instead we saw the opposite. Overall, the patients came in with an initial pain score of 40, which dropped to 29, and that was a statistically significant 25% reduction. The reduction was actually 33% in the morphine group, which was even more statistically significant, more so than the oxycodone drop, which actually didn't reach statistical significance. But the study is not powered for pain as the endpoint, just for the levels of the opiates. So we concluded that co-administration of vaporized cannabis with oral sustained relief opiates is safe because we saw no side effects, and it appears to enhance analgesia, although it did so without raising the blood levels of the opiates, which suggests that it's not a pharmacokinetic interaction, but a so-called pharmacodynamic interaction. So the Institute of Medicine, which I alluded to earlier in 1999, said in their report, Marijuana as Medicine, accumulated data indicate potential therapeutic value for cannabinoid drugs in pain relief, control of nausea and vomiting, and appetite stimulation. Doesn't sound like there's no therapeutic effect, which makes it Schedule 1. The therapeutic effects, they say, of THC are best established. Well, that's because you can't study the therapeutic effects of cannabis. The effects of cannabinoids are generally modest. Usually there are more effective medications. Well, that's true, but in cancer care, we approve drugs that maybe benefit 5 or 10% of people with a certain cancer that are way more expensive than cannabis. So again, thinking of symptoms that are challenging to us in caring for patients, anorexia, weight loss, cachexia, nausea and vomiting, cannabis is the only antiemetic that also increases appetite. And it's the only antiemetic that also can alleviate moderate pain, anxiety, and depression. When I go to cannabis conferences, there's two, the International Cannabinoid Research Society, which is all about in the test tube and animal models. They often describe cannabis-induced euphoria as a side effect. If it's a side effect, I don't consider it an adverse experience, particularly in a terminal patient. And is a single treatment that increases appetite, decreases nausea and vomiting, relieves pain, and improves mood a potentially useful tool in palliative medicine? So I see patients, and instead of prescribing 5 or 6 different pharmaceuticals, which all can interact with each other or with the chemotherapy that the patient may be on, I can say, try one medicine, and that medicine is cannabis. And I always ask my patients, what brings you joy? The number of cancer patients who tell me that gardening brings them joy is not insignificant. I think if you're dying, or if you feel that part of you has died, the ability to bring life out of the ground is a blessing. And if patients can in fact grow their own medicine, that is very empowering and gives people back hope and a sense of control over their life and that they're doing something for themselves. This is just one example of a grateful patient. Hi, Dr. Abrams. I'm contacting you to see about getting an extension on the medical marijuana letter that you issued me last year, which expired on March 21st. Although I did not use it until my last 5 sessions of chemo, me getting over the stigma of its use, it did what no other drug could do, completely solve the severe nausea I had. This is a 38-year-old guy with metastatic colorectal cancer. It allowed me to play with my children, attend their sports and school functions, and just function very normally in day-to-day activities. I cannot thank you enough for giving me that option. I am currently on a chemo vacation after a clean scan, and the only time I use medical marijuana now is when I have trouble sleeping. I would like to continue to use it for that purpose instead of relying on pharmaceutical options. So, in conclusion, I just wanted to say that there's increasing evidence that cannabis in and of itself may have some anti-cancer activity. Interestingly, this research was first done at our National Cancer Institute, published in 1974, quickly went offshore. Most of this is now done in Spain and Italy. Cannabis has antioxidant, anti-inflammatory effects, and also may have direct anti-tumor activity by way of the cannabinoid receptors being involved in inducing apoptosis and impairing tumor vascularization. Gliomas, particularly glioblastoma, and skin tumors seem responsive in animal models. If you take nude mice who don't have an immune system and implant human tumors into them, these are the malignancies that seem to respond to cannabis. Cannabinoids induce apoptosis or programmed cell death. They also help differentiate tumor vasculature. Cannabinoids also decrease the activity of the matrix metalloproteinase 2, which is involved in increasing tumor invasiveness. So this is all pretty exciting, but I don't think it means that cannabis cures cancer. And for those of you that keep track of the world of cannabis oil, hemp oil, so-called Rick Simpson oil, is a very highly concentrated extract of very high amounts of THC and or CBD. And many people are using this in conjunction with chemotherapy and radiation and surgery, or instead of. And the proponents are claiming that they have cured a number of cancers. I keep saying if they have, they need to send that information to the National Cancer Institute best case scenario so that somebody can investigate it and see. Yesterday, I believe I mentioned about a friend of mine who's a cannabis activist with stage 3B lung cancer who was treated with chemoradiation and took cannabis oil throughout that and went to surgery and had no tumor and is now a year and a half post-op and remains with a negative PET scan. Does that mean she's cured? I'm an oncologist. In cancer, cure means 5 years disease-free survival. We have not been using these cannabis oils long enough to claim cure. So I think it's something that's worth investigating. I'm working with one of our neuro-oncologists now to try to do a small pilot study in patients with glioblastoma to see how cannabis oil and temozolomide, the chemotherapy we use for brain tumors, may interact pharmacologically. If you want information on cannabis and cannabinoids in cancer, I'm one of the editors of the NCI Physician Data Query, Complementary and Alternative Medicine. That's NCI PDQ CAM website. And we have on our webpage information about cannabis and symptom management, as well as every month I get 3 or 4 articles of basic science information about cannabis and cannabinoids as anti-cancer agents, so we're always adding new paragraphs monthly to that section. My colleagues, however, in oncology say, Donald, it's a plant. What are you doing? In these days of nanotechnology, targeted therapies, and gene therapy, why are you continuing to advocate for and study a plant as medicine? And the answer is, being integrative, I think this is how we get back to the roots of medicine. So with that, I thank you for your attention and invite you again to come to Vancouver to the Society for Integrative Oncology's 10th annual conference this October. Thank you.